This morning, we're going to be simulating how to insert a central line. Obviously, this is not a real patient. It is a simulated environment, but we'll try to be realistic as possible. So we're going to start our process for doing a central line by doing a chart review, making sure we check the INR and the platelet counts, and for any contraindications, and double checking and making sure that the consents for the procedures are signed. We also want to double check allergies, and we want to hook them up to our EKG, pulse ox, and blood pressure and ASA standard monitors. And we're also going to have the alarms audible for this position. So we would simulate going, wash our hands to start the procedure, and then we would place the patient in 15 degrees Trendelenburg to help that venous pressure come forward to identify the internal jugular vein on the right side via ultrasound. We don't have an ultrasound here, so we would simulate it, and we would use the ultrasound to distinguish between the internal jugular vein and the carotid artery. So then we would start by opening our kit and looking at what's inside the kit and starting the procedure itself. So here we have our central line kit. It would come in a plastic sterile packaging, in which we would take it out of the plastic packaging. We're going to open this up sterilely. There are 2 layers to this kit in terms of the steps that we use them. So we'll start by opening away from us and then towards us and then left, making sure to only grab the inch border, and then we'll go to the right. And then, like I said, just trying as best as possible to stay sterile. And then we'll get this to open. In a real hospital environment, we would have a side table to do this on. Here we have our sterile towel. We will take this and put this aside for now. And then we have our CHG ChloraPreps and our hairnet, which we will don sterilely. We will place our hairnet on as well as our face covering. And then we will use the CHG to sterilize the site for insertion. And we will do that in circular motions from inside to outside, and we will let it dry for 3 minutes. While that's drying, we will go ahead and continue to open our kit and then don our sterile gown. Once donning our sterile gown, we're going to don our sterile gloves. We do not have sterile gloves to practice with, but I'll demonstrate the technique as best as I can using these regular gloves. So without putting our fingers past the cuff, we're going to grab the cuff of the glove we're putting on, and then we would grab the sterile glove cuff, drape it over, and use our sleeve to pull our hand into the glove. So after donning our sterile gloves, we will go further into the kit, and we can see that we have our sterile drape. It is fenestrated to give us a working area. We want to ensure that it has been 3 minutes has passed since our CHG cleansing and that the patient is fully dry. We're going to have the patient rotate their head to their left, exposing the right clavicular area. And then we're going to tape the drape, and keep in mind of the indicators. We would crease the drape and remove this adhesive protection to allow it to stick to the patient. We would place it over our working area of where we are planning to insert the central line and allow it to fall. Following the arrows, we would pull left, and then we would pull right, disregarding our working space for the simulation. And then with it adhered to the patient, we would pull it down and then have assistance pulling it up to keep it sterile. So after donning our sterile gloves, we will go further into the kit, and we can see that we have our sterile drape. It is fenestrated to give us a working area. We want to ensure that it has been 3 minutes has passed since our CHG cleansing and that the patient is fully dry. We're going to have the patient rotate their head to their left, exposing the right clavicular area. And then we're going to tape the drape, and keep in mind of the indicators. We would crease the drape and remove this adhesive protection to allow it to stick to the patient. We would place it over our working area of where we are planning to insert the central line and allow it to fall. Following the arrows, we would pull left, and then we would pull right, disregarding our working space for the simulation. And then with it adhered to the patient, we would pull it down and then have assistance pulling it up to keep it sterile. Once the patient is draped, we can look further into our central line kit. When we open it up, the first thing we will see is a sterile flush. We can open this sterile flush up and throw this in the trash while keeping it sterile. So we'll throw that in the trash. And then we will just place that inside the sterile kit for now. We have our tegaderm, which we will place in a sterile area. Usually our working space, we'd have the sterile drape still available. So we will say that this is the sterile drape. We have our 1% lidocaine for injection and making our skin wheel. We have our actual central line catheter with our proximal and distal ports. And then we have our guide wire, as well as our introducer needle, our arrow kit, a blunt tip needle to draw up the lidocaine, as well as a 27 gauge to make our skin wheel with the lidocaine. So we want to start first by taking our guide wire, and we want to ensure that it is ready to be introduced to the introducer. So we want to make sure that the tip is curled inside and make sure that it flows freely without any tangles or knots. and then we can just place the protector right back on there for now. We're going to uncap our proximal port while keeping this sterile. Going to uncap our proximal port, and then we're going to flush the ports and ensure that there's no air in the central line. And we can just do this directly into the plastic tray. So after that is complete, we're going to cap this port back, and then we're going to flush our distal port. And ensure that it flushes, and then we will leave this uncapped. Once that is complete, we can take our blunt tip needle and drop our lidocaine, and this will be simulated lidocaine. After that is finished, we can take the blunt tip needle and either put it back in its protector, or we can stick the needle into the little sharps holder there. And then we can attach our 27 gauge subcutaneous needle to inject our skin wheel of lidocaine. After that is complete, we want to make sure that our 3 mil syringe is attached to our introducer needle, and ensure that that is ready, and ensure that the catheter moves freely off of the needle. We want to make sure that we have our dilator readily accessible, and then we have our scalpel as well as our hemostats with our suture to secure the line afterward. All right, once our kit is ready and we're ready to start our procedure, we're going to ensure that using the ultrasound, that we're still in proper placement and we differentiate between the internal jugular vein and the carotid artery. Once that is done, we are going to take and uncap our sterile needle with our lidocaine and inject a skin wheel around the insertion site, and we can place this in our little sharps holder. Once the area is numb, we will take our introducer needle with a 5 mil syringe, uncap the safety, and then we're going to maintain negative pressure while aspirating, and we're going to insert at a 35 to 45 degree angle, aiming at the ipsilateral nipple line. So with the ultrasound in place, we would use this for guidance to maintain central line, and then we're going to insert while maintaining negative aspiration and wait to get flash. So once we get flash, we can see the blood in our syringe. We're going to stabilize our needle and get our guide wire ready. And then we're going to remove our needle from our catheter, place that in the sharps container, and then introduce our guide wire into the catheter, threading this in. So a few different techniques. I was taught the pull and push technique. So you hold the guide wire and then you advance it further. While we're advancing the guide wire, we want to maintain attention to our ECG and look out for ectopy. And then once we are ready, we're going to secure our guide wire, hold our guide wire in place, and then remove our needle or our catheter. And then once our catheter is in, we're going to stabilize our guide wire at the skin surface and remove the catheter. When that is done, we're going to take our scalpel and make a small incision away from the guide wire for the skin to introduce our dilator. So then we will take our dilator while maintaining control of the catheter. We can take our introducer for our dilator, place it over the guide wire while also still maintaining stability of the guide wire. Once the introducer meets the skin surface, we will let go of the guide wire at the surface and grab the guide wire on the other side of the dilator, and we will introduce the dilator into the skin. Once the dilator is out, once the dilator is in, we will then remove the dilator while maintaining control of the guide wire again. We will remove the dilator and then grab our central line. Same thing again, maintain control of the guide wire at the surface of the skin, and then introduce our central line onto the guide wire. So while I'm doing this, I'm maintaining control of the guide wire, making sure that it is not coming out. Once the central line, we can see that come out of the distal port, we can then start to advance. In the real scenario, I would have much more guide wire to work with, and then we will advance the central line into the patient while maintaining the guide wire. So we will advance, keep advancing, and then once we are at the skin surface, we can remove the guide wire. And then we want to ensure that we can aspirate blood from both ports. And then we would flush with sterile saline both ports and then cap them sterilely. All right, I placed a sterile towel just for the sake of being able to suture, but I forgot to mention, when we were advancing the guide wire with the central catheter, we want to use our ultrasound and get a longitudinal view and take a picture of the longitudinal view and place it in the chart to ensure that we were in the vessel. Once this is down, and like I said, we aspirated blood and flushed the ports with sterile saline and then used sterile caps. We're going to secure the central line with a suture. So we have our suture kit here, and then we have our hemostats, and we will bite the needle and then ensure that it is correctly on the hemostat. Once it's locked in the hemostat, we can pull the suture free, and then we will get an underbite on the towel and then go through the holder for the central line, and then we will pull it through. Once it's pulling through, you let go of the needle with the loose end out. We'll do 3 counterclockwise, and then we will go 1 clockwise, and then 1 counterclockwise again. This would be repeated for the other side. We would have an assistant clip the suture at the surface of the holder, and then we would repeat it on the left side. And then after this is secure, we would place the sterile tegaderm over the central line and then call for a chest x-ray to ensure that it is properly positioned.